Afternoon. Thank you for inviting me. I'm very happy to speak today. I'd like to share our experience at MD Anderson with the BRAF inhibitors and how that might apply to the ECD patients when they start using these as well. So over the next 15 minutes, I'm just going to go over briefly kind of a background of the BRAF inhibitors and how they've been used in melanoma, and also how they're being used as a target agent in ECD. And then kind of go into more detail about the common skin effects, because there are so many, and this is one of the most common side effects of using these BRAF inhibitors, and the specific risks of developing skin cancers and precancers on the BRAF inhibitors. So it's really exciting back in 2002 when they found this specific mutation in melanomas. It was a BRAF V600 mutation, and it basically was the beginning of the selective class of these inhibitors, of which the first one was vemurafenib, and basically targets a specific mutation in the formation of the melanomas. And what was even better was that over half of the melanomas actually had this mutation. And so it got kind of fast-tracked through the FDA and approved in 2011. And we've seen a lot of patients in melanoma use them, but also actually in thyroid cancer as well. And so how does this happen? Well, it's kind of like the standard process for a lot of the different types of cancers. There's a standard therapy, and it becomes limited because, number one, it doesn't work so well. It works partially. It doesn't change your survival rates. And prior to interferon alpha therapy in ECD, the mortality rate in ECD was as high as 57%. And there's a lot of treatment toxicities with all the different therapies, including prednisone or chemotherapy. And so there's an evolution into making these very specific targeted agents that are tumor specific. So you check the tumor and see if it has a mutation, and then get that medication. And it's the same thing with ECD. They actually looked at it more closely, and it's actually quite interesting when I went through the research too. And they tend to have a better toxicity profile because it's specific. It's not just kind of like blasting chemo at everything, so you have bone marrow suppression or GI toxicity and cardiac toxicity. But you still, like always, will have some side effects, and so we're going to go through some of those side effects. So here's a paper I just happened to look at, and it was interesting to look at ECD treatment over the years. And you notice it starts off with the corticosteroids and then goes through traditional chemotherapies and then interferon, and then finally the evolution into targeted therapies, and the most recent in 2013 being the vemurafenib, which we're going to discuss at length today. So ECD, as everyone knows, is the rare form of non-Langerhans histiocytosis, and it's multi-organ, it's systemic, and it affects the skeleton, the skin, thoracic and abdominal organs, especially as we just talked about the kidneys, and the CNS. Early case reports show promise in ECD patients, and there's not a whole lot. There's these very small case studies of 3 patients or a handful of patients at a time. But what was interesting was a few of the cases that I read, they had over half of the cases where they looked at the tumors in ECD patients. They also showed the same BRAF V600 mutation. What was interesting is that they even had to decrease some of the doses. We'll talk about why they decreased the dose of the vemurafenib in ECD patients, but they still had improvement even at the lower doses. So overall, even though I'm going to show you a lot of skin side effects, this is in a specific group of melanoma patients who get the 960 milligrams twice a day, and it looked like in some of the early ECD studies, patients were using half that amount, if not less than that a day. So what are the side effects in general on using BRAF inhibitors? The most common is arthralgias, and this is a specific issue with ECD patients because of the skeletal involvement. And that's why in some of the early kind of case reports, they had to decrease the dose because of the overlap of side effects in the patient profile already, plus with this new medication. But the other ones include fatigue and nausea, diarrhea, fever, and skin reactions. Skin reactions are super common on BRAF inhibitors. Greater than 70% of patients will experience some kind of skin issue. So we'll talk about specifically the different skin reactions. The most common, and it's very general, it's just going to say rash, but it's just kind of a maculopapular and a pustular rash. And I'll show you pictures of all of these things and kind of show you in detail what we do to treat them as well. But the numbers I put in parentheses are, first, it's the vemurafenib incidence, about 15 to 18%. And the second number is with dabrafenib, a newer, similar agent. So in the maculopapular rash, you can see easily a quarter of the patients have that. Photosensitivity is almost specific to just the vemurafenib, about 7 to 12%. Keratosis pilaris, or follicular plugging, I'll show you pictures of all of these. It's about 8 to 29% with the vemurafenib, and more, almost double that in the dabrafenib patients. There's a hand-foot skin reaction, again, about 10%, and almost double that in dabrafenib. Seborrheic dermatitis, which is a kind of dandruff-like condition, and then alopecia, which is hair loss. And the last one, which is kind of the one that gets everyone's attention, is actually the formation of precancers and skin cancers, up to 25% with either medication. Okay, the first is the Maculopapular Rash. It's basically small, itchy red bumps and pus-like bumps, and it sometimes looks like just redness. People get a generalized redness of their face or their trunk, and they get kind of a scaly, kind of dandruff-like condition called seborrheic dermatitis, and it often feels a little swollen. The skin is kind of warm to the touch. And where is it located? Mostly up on the upper half of the body, so the face, scalp, ears, shoulders, chest, and upper back. And sometimes it drifts down, and we see a little bit on the lower body, and even less so on the legs. So here's one of my patients, and basically just has a real kind of faint pink-red bumps, and if you can look at it, there's some pustules, which are just like yellow pus-filled bumps, and they're kind of in different stages. Some are brand new and erupting, and some are just small and kind of fading, so it's kind of a constant ebb and flow of the rash while they're on the medication. And this is a close-up, and you can kind of see on the left some pus-filled bumps and some that have scabbed over, and a lot of just general redness to the skin. This woman had a little more exuberant response. You can't quite see it, it's kind of dark on her face, but it's actually bright red, and there's a lot of small pink pustules again all over her upper chest. This is another patient who also kind of shows the distribution well, because it's really on his uppermost chest, and he has a little bit under his breast area, and then diffusely throughout his face. This patient also has similar distribution on her upper chest, throughout her face, and if you can kind of see on her chin, she's starting to exhibit a very kind of more rare response, but one that I see a lot, because when it gets to this extreme kind of presentation, they start sending him more to the dermatologist. But this is not that common. I just want to show you. It's not to scare anyone, it's just to show you what it can look like, because it becomes very focused on the central face. There's a lot of red, crusted kind of look, because the pustules almost kind of meld together, and they are very itchy, tend to be very tender, and also a little bit disfiguring, so patients are very upset. So this is something we try to jump on right away. And so within our services, when patients start seeing anything that looks something like this, they get sent over to me right away. And this is someone I saw this summer, and it's kind of dark in here, but it's actually very yellow, kind of crusted. It looks kind of like what they call impetigo, which is like a superficial bacterial skin infection. It's called honey crusted, and it's all kind of matted down together. And these patients, after we start them on sometimes topical steroids, oral antibiotics, sometimes oral steroids, they improve dramatically, and they come back for very scheduled routine visits. And the reason there's no post pictures is because after they come back, we're so happy to see them improve, we forget to take a picture of them. But at least they get at least 80%, 70% improvement, so definitely manageable to keep them on their treatment so they don't have to stop. And what are some strategies before this happens? Well, we tell people to be really proactive, and that means trying to maximize their barrier, health, and trying to really take care of the skin before they start treatment. So we tell them to emoliate a lot with very bland moisturizers that don't have scents, don't have parabens or preservatives. And this is just a list of a couple, just Vanicream, CeraVe cream, Cetaphil cream. You also have to avoid sunlight because there's photosensitivity associated with these medications. And also, not everyone's from Texas, but that's a big issue here because year-round people are out in the sun. But a lot of our patients come from around the country or even outside the country, and there's colder climates, harsh winds. We tell them to use mild soaps, avoid perfumes or any kind of other unnecessary topicals, and avoid tight-fitting clothing or rough clothing like woolens or jeans. Again, the rash is more severe, and if you look at those patients, it was all in their sun-exposed areas. It gets much worse because a lot of times, even though they're indoors, they're still getting some light when they do small errands, so their face is more sensitive. And then we tell them to use specific sunscreens, and they're not all created equal, so we tell them to look for ones that have zinc oxide and titanium dioxide because they're better at blocking the sun, and they're actually less reactive and less allergenic, so patients tolerate them very well. But more importantly, we also tell them to avoid the sun and try to use basically physical blockers like clothing and hats and sunglasses, and just seeking shade whenever they can. And then for women, we do recommend water-based makeups, and also it's a good cover-up for some of the rash too. But as I mentioned, when they do come in and it's kind of fulminant and kind of all blown up, then we start giving them various topicals that are to begin with over-the-counter things, like I mentioned, the moisturizers, and also using cool compresses just to cool the inflammation down. and also oral antihistamines for itching. And then we start prescribing topical steroids, also topical antibiotic lotions, and then sometimes short courses of oral steroids. We don't really have to go that way too often. But some patients with chronic inflammation, we do put them on low-dose antibiotics, not for their bacterial killing properties, but more for their anti-inflammatory properties to keep the inflammation down and to make it comfortable for them to proceed. So keratosis pilaris is a funny-looking rash, and it's really interesting because I'll see these patients for a baseline visit before they start treatment, and their skin is perfectly smooth, just normal skin. And then after they start this medication, within a couple of months, they get this real prickly chicken-like skin. It feels like there's little spicules on these, basically their hair follicles. Because as you understand the pathway, you realize that with the BRAF inhibitors, you actually get upregulation of a lot of skin processes, so things that grow. So they get these little prickly bumps. They usually don't bother the patient, but they clearly know they've started. They're like, these were not there before. And so patients do different things to try to improve them. But basically, they're usually on their arms and their legs, sometimes on their back. And those are usually the general areas. Sometimes it spreads a little bit to the chest. But in the picture, you can barely see. They're just like little, it's like almost like getting goosebumps. They're little prickles, but they're there all the time. And they're not just soft, they're actually kind of hard. And it's just another form of follicular plugging. There's a lot of keratin or skin protein kind of stuffed into the hair follicle. And some patients will call them blackheads or pimple-like lesions. And this is a close-up of them. But all those little faint brown dots, there's actually like dead keratin or skin stuck in there. So how do you treat it? Don't scrub it. Patients start trying to scrub it out, but it's not that kind of one-time process. It's ongoing. So you just basically anger it, make it mad. It just keeps coming back. So it's not a good way to treat it. So we give them keratolytic creams. It's like chemical exfoliation. So not physically exfoliating, but giving them a lotion that has a chemical ingredient that's acidic, that softens the skin and helps it to come out. So these are ones like lactic acid or urea or glycolic acid. And there's a lot of over-the-counter products that have something like this, like amlactin, lachydrin, Carmel 20, and there's a lot of them. And so we ask them to kind of use these regularly, and that really helps to soften the skin. Seborrheic dermatitis is not exclusive to patients on vemurafenib. We see it all the time, especially in patients who are hospitalized. But basically, there's like a, quote, dandruff of the face. You get scaliness, kind of yellow, waxy scale around the face, usually around the eyebrows, around the nose, in and around the ears. It's very common. Most people are asymptomatic. They just start noticing they're getting scaly. They're like, I don't know what's going on. But there's probably some imbalance in the skin because it's caused by an overgrowth of a yeast on the skin that's on everyone's skin. And sometimes patients will often have it even on their central chest. So this picture shows you, like, this is a patient, it's very classic, right in the middle of the chest. They'll have a little area of kind of scale. It's a little waxy, meaning it looks kind of greasy. It's like stuck on. And then the other side shows just like it's very much in and around, sometimes inside the ear canal too. So this is a pretty straightforward treatment. You can use over-the-counter anti-dandruff shampoos. And the usual ones over-the-counter are great. Selsun Blue has selenium sulfide, or Head & Shoulders has zinc. And you can use any of these over-the-counter shampoos. And we tell them to wash all the areas. So that means you use it as a face wash, a body wash, and a shampoo. So you lather those areas that are involved. You let it sit for about 5 or 10 minutes and you rinse off. It's an easy way to take care of it. If it's more inflamed, some people get very much an inflammatory response to this rash, and so they need more than just topicals that are over-the-counter. We'll give them prescription anti-yeast creams like Nizoral. And sometimes they even need a little hydrocortisone, just over-the-counter 1%. That kind of helps calm the inflammation. Alopecia, I actually haven't seen it too much, which has been good because these patients are on the, as I said, the full dose of the vemurafenib, but it's it's also a reversible hair loss. It's pretty mild, and the texture of the hair changes. It becomes a little more fragile or a little thinner in texture. Cystic lesions, again, this is in line with things growing or, things that are in the skin. So this patient had a lot of cystic lesions. This is not a picture of my patient. This is another patient. And basically, you can kind of see in the picture, even though it's so dark, it's bumpy. You see all these little, like, white little nodules under the skin. Did not have any of those before treatment. They kind of are eruptive. They come up all of a sudden. And as you can imagine, they're uncomfortable and they're unsightly. And it's very distressing. And so in this case, topicals are not going to touch this. They're too many. They're too deep. So they may go on to a topical retinoid cream, which is like a Retin-A cream, or an oral retinoid. And they just get monitored. And the picture below, which you can't appreciate as well, but all those bumps are gone, and that's just from taking an oral vitamin A pill. Okay, the hand-foot skin reaction, I have to say I see that a lot. Basically, there's swelling and redness of the palms and soles. And what's interesting is they get these really thick yellow calluses on the weight-bearing areas of their feet. And people go, oh, they always had calluses. And actually, no, I've seen these patients before they start, and their feet are baby soft. They're just fine. And they come in with these sheets of thick yellow plaques. And it's all because of the medication. So obviously, imagine walking on a hard plaque all the time. It's very tender and it's very painful. And there's a couple theories as to why. People think maybe there's increased concentration of the drug in these small vessels in this area, and so there's some direct injury or cytotoxicity to the cells there, or that it's just that because of all the pressure and weight bearing and the stuff you do with your hands, it causes it to keep re-injuring itself and doesn't give it a chance to heal. But there's no definite reason as to why this happens. And so this is a patient, and they come in with just very warm, red, swollen palms. So the treatment is, basically, a lot of these patients travel a lot, so they're always on their feet going to appointments and just traveling. So trying to rest, very straightforward things, thick socks, gel padding in their shoes, and no narrow, toe boxes. They need big toe box shoes, like Crocs or Danskos, big shoes, and cool compresses, and trying to avoid heat and friction. And again, because of the thickening of the calluses, I have patients who are very diligent. They just keep using those keratosis just to get it off, even though they know it's going to come back in a week. They just don't want it, and they'll just keep working at it, but it can be softened with some of the topicals. So this is the area that people are most concerned about, and this is what I'll spend a little time on. It's the precancers and the skin cancers. It's very, very unique to the BRAF inhibitors, and specifically the vemurafenib, even more than the dabrafenib. So patients, and I think this is partly what I've seen and I've read, is that patients who have a lot of prior photo damage or sun damage are ones that are tend and more prone to get these because they were already on the brink of getting them, and this was like the final straw, just kicked them over. And so they start developing a lot of these lesions, often within the first 2 to 8 weeks. And so in this patient, he probably started not very long, but within about a month, he comes in and he has literally all these new scaly, they don't have to be tender, scaly little red bumps on sun-exposed areas. And the highest risk areas are your head and neck and your arms and your hands. And so he comes in with a lot of these lesions, and so when they come in, if they're small enough, we just try to treat them with liquid nitrogen, but if they get larger, then we have to start biopsying them. But as I mentioned, it's just the classic areas where we see sun damage in our older patients, just on your face, ears for men, the neck for the men, nose, on their upper chest, and their bilateral forearms, and the dorsum of their hands. And this patient also had numerous lesions, and the little rulers actually are by the large lesions, which we ended up biopsying, which are oftentimes squamous cell cancers. That's the type of skin cancer that erupts when you're on vemurafenib. You get this kind of spectrum of growths. You get warty growths, precancers, and then the squamous cell cancers. This is a patient I saw like last month, and I see these patients like every month. And people don't believe, and they go, it just popped up, and it does. These specific type of squamous cell cancers called keratoacanthomas pop up. So from 1 month to the next, he had nothing, and then literally came in with all these dome-shaped, very hard skin cancers. And again, these are very treatable. And because they're under such close follow-up, it's really not an issue, except for the fact that there's a lot of them. And then those patients, there's actually nothing published, but in my own experience, I've had probably 4 patients now that I put on the vitamin A pill. And amazingly, we actually wrote it up, though. We did write it up. And is that one patient came in and had like 80 to 100 of these small little precancers and wart-like growths. We started them on the Soriatane at 10 milligrams a day, and within a month, they came back and had like 1. And so they were like obviously convinced. Well, then it gets even better because then the insurance doesn't cover it, so they get off the medicine. They come back and they've erupted again, and then we put them back on and it goes away again. So that was kind of like an internal control, not on purpose, but because of insurance problems. But it definitely has worked for the patients who have a lot of lesions because it's very stressful to be undergoing treatment for your melanoma and then to be erupting in other skin cancers alongside that. So it's very tolerable. We manage it very well by following their labs every month, and they can continue on their treatment. So this has been very helpful for patients. So treatment, as I mentioned, the precancers, we'll freeze them. If they're extensive, they might use some chemotherapy creams, or we might do a chemical peel on them. There's warty growth, it's very similar. And then any suspicious lesions, we'll actually, mark, biopsy, and then they'll go on to have surgery, excision in the dermatology clinic or with a specialty Mohs surgeon. So our dermatology consult service is there just to support all these patients, especially at MD Anderson, who are on various trials, and they're trying it on very numerous different types of cancers. And our goal is to treat through these side effects. By being available for same-day consults, patients call, the doctors will call in the morning all the time saying, oh my gosh, this rash is bad, and we'll try to get them in that day. And we work with the primary team to kind of see how severe the rash is, because often they're telling us, can they keep taking it? Do we need to stop? And we really try to help control the side effects as much as we can so they can keep going. Sometimes, though, we have had patients who have to decrease the dose temporarily just to get a break, or they even go on a drug holiday where they just stop the medicine so their skin can heal and they can restart. But the goal is to really maximize all the benefits they can get from the BRAF inhibitor therapy. And patient education has been, I think, really important. I think when the patients really knew up front what they might get into, they were a lot less scared, really kind of involved and able to start doing treatments at home and not waiting to get into dermatology. They already had, ideas of what to use. And the rash is very common. It's not an indication of an allergy. It's just because it's basically turned on by the treatment. And we really tell them to kind of be proactive and tell the provider as soon as possible so we can get them in as soon as possible. And sometimes we have to enlist local dermatologists to help as well. And of course, patient education is really helpful when you have people with you. So we always encourage someone else besides the patient to help take notes and to kind of hear what we're trying to explain to them. So in summary, the skin reactions are very common with BRAF inhibitors. And as it continues to kind of percolate through all the different fields, I see ECD, it's already starting to, is that there may be similar problems with skin, with skin issues, and they'll be referred to a dermatologist, and usually dermatologists who have experience with the BRAF inhibitors. And as far as being proactive, just kind of improve the health of the skin as much as possible before starting the BRAF inhibitors. And basically anything that's suspicious or you're worried about, you should go see a dermatologist so they can do a biopsy. And basically as much patient involvement and knowledge is probably going to be the key to being able to tolerate these BRAF inhibitors. All right, that's it. Thank you.
Questions?
Have you heard of the SPF clothing? Like
Yes,
shirts?
yes. Yeah, so the clothing.
And they're effective?
Yes, they are very effective. It's called, basically it's UPF clothing. It's just a rating they assign to clothing versus SPF they do for sunscreen. And there's two companies that I recommend regularly to patients. One is called coolabar.com, and the other one is sunprecautions.com. And sunprecautions.com clothing has actually been FDA approved, so it actually can be written as a medical device because there are patients with certain skin diseases that they can't have any UV light or they'll blister or develop more skin cancers. So there is actually very good clothing out there, and it does work. One is called coolabar.com, C-O-O-L-O, sunprecautions.com. They have Solumbra clothing, S-O-L-U-M-B-R-A.
I have a question.
Uh-huh.
My daughter has the juvenile granulomas on the front and the back of her torso.
Uh-huh.
And I know when we first started back, they said that her dermatologist said, oh, that'll go away within a year or so. It's been probably over 7 years. Will that ever, is there an opportunity to ever have that go away or anything you could do for it? She's been done the topicals. Mm-hmm. She's been through interferon, Kineret. They've kind of shrunk some of it, but that just never disappeared.
Yeah, I don't know because it's so diffuse, because then you'd have to go to higher and stronger systemics that, again, have more side effects. And so it depends on how much they are symptomatic or painful, I guess. And so it just depends on, because you have to trade side effects every time you try something stronger.
Okay.
Another thing we used this summer for sun protection, because we wanted to go to our grandkids' ball games, Sportbrella has, it's an 8-foot umbrella or a 9-foot umbrella that you open up and just lean on the ground, and you can set 2 or 3 lawn chairs inside of it.
That's great. That's good to
And
know.
it's 50 plus SPF.
Great. You know, the Cool Bar website also has a lot of umbrellas in there too. And a lot of these websites actually do have a lot of, not just clothing, they have a lot of accessories. That's great. Thanks. Questions?
I have a question over here.
Okay.
Yeah, what soap do you recommend for their face and body?
So for the body, I really tell patients to use liquid body wash. It's less drying than bar soap. And Dove is really good. Dove's a great brand, and so is Oil of Olay. They're really mild, and you can get fragrance-free versions of both of those. For the face, especially when patients are on clinical trials or, you know, having a lot of chemotherapy, we tell them to avoid soap-based face washes, so we recommend like Cetaphil. It's a non-soap cleanser.
What was it called again? I'm sorry.
Cetaphil, Cetaphil. And you can find that at any drugstore. It's a good it's used in a lot of studies. When people are on studies, they'll be given this as part of the study because it's so bland.
And is there any way to get a copy of all this information that you put up there?
Yeah, actually, I have a handout, which I didn't have with me, but I can get that to somebody, and then they can pass that out. And I actually have a really good handout for sun protection, which I have as well, and I can give her that one. And that one has all the different sunscreens that we recommend and the websites, and there's a coupon. And so I'll get those. It's like a 2-page handout, so we'll get that to you guys.
Okay, thank you.
You're welcome.
And that the alopecia is fairly uncommon with verapamil, but my wife has had problems with that. And is there anything that you will do for that? I know like zinc and selenium sometimes help with like hair loss for people who are on Depakote, or are there any other types of things that you recommend?
No, but I have a lot of patients who have alopecia from lots of treatments. And so, you know, I actually did a couple of review papers on chemotherapy-induced alopecia and have recently reviewed it again. And it's just one of those areas where they just haven't done a lot of new research. So the things that I recommend for my patients is, you know, definitely like making sure that the scalp is as healthy as possible, so making sure there's no dermatitis. The second thing is actually using Rogaine. Rogaine 5% is the men's strength. I have all patients use it, not just the men. And that can help to, you know, bring back some hair. But a lot of times I'm telling you it's pre-programmed. I mean, some patients come back, you know, most people do get their hair back to some extent. But there's nothing actually new to kind of speed that up. Although they did look at Latisse, there was a trial, and I never heard about Latisse. I think you might have heard of it. It's the one to use to stimulate eyelash growth. And so it's a cosmetic, and they thought, wow, that's a great idea. Why don't we put that on people's scalp after chemotherapy? And I know they did some trials, but there's no data out. But that may be something that might come down later. Okay, welcome.